So good afternoon, everyone. At the outset, I would like to thank the organizers for giving this opportunity to me to talk about the assessment and utilization of older diseased donor kidney. But initially, for the first lecture, the speaker, Dr. Sanjay Kalra, who was my contemporary in All India Institute when we were doing together DM in nephrology and endocrinology, and he stated that there is no age definition for old age. So it probably aging looks like a number, but the topic given to me is the older. So who is actually old? I feel that none of us in this hall are old. So all of us are young, both biologically, physically, mentally, socially, by all means, including economically. So we have to do more. So, so the topic is the how to utilize this older, at least age-wise, the deceased donor kidneys in our setup. The transplantation is the treatment of choice for end-stage renal disease. The need of transplantation is very much required in our country. As per the statistics in 2023 in India, there are more than 11,000 live-related transplantations and 1,800 only were the deceased donor transplantation. Probably the Tamil Nadu, Telangana, Maharashtra, Karnataka, Gujarat are leading the show with a lot of deceased donor transplantations. But definitely, as per the statistics, there's a definite need for improvement in the expansion of the donor pool in our country. But there are some definitely problems as far as the donor age is concerned, as for the several comorbidities associated with them, especially like hypertension, diabetes, and the presence of diseased vessels, which are very, very important in our kidney, are all the major risk factors for them not to have a proper kidney function after the transplantation. But however, there's something called expanded criteria for the donor, and probably which requires more attention and how to select them out for the kidney transplantation. And there's an emphasis only to guide us how to balance the demand and supply mismatch of kidney transplantation donor recipient in our country. In order to expand the donor pool, we have some definition of that a donor who is actually less than 60 years of age and age more than 60 years of age. At the same time, donors between 51 to 59 years of old age, but any of the two following risk factors such as hypertension, cerebrovascular death, and serum creatinine of more than 1.5 milligram per deciliter. If the serum creatinine is more than 3 milligram, is not a contraindication. If the serum creatinine is steadily falling and the donor is known to have a normal renal function in the recent past. So these are the things which we can actually select out, and the donor, though he has got an expanded criteria donor, it can be. And there are definitely some benefits of utilizing this particular older deceased donors, which will increase the donor pool, and it will definitely reduce the waiting list for transplantation. And scientifically, we also know that there's an improvement in the outcomes of the patient after the expanded criteria donor as far as the age is concerned. And these are the changes which are in a cartoon explaining about how the changes take place in the kidney after during certain aging process. And also they can decrease the outcome of the graft also after that. This is basically that during the aging, as the age probably after 30 years, there will be some changes in the human body as for the kidney function is also concerned, maybe because of the cellular senescence and the defective autophagy, and also the mitochondrial dysfunction, inflammation, and other so many activities which are taking place. And with this, when we take the graft, probably there can be a left graft function, and there's an increased immunogenicity also will take place, leading to the rejection process in them. So some of the studies which I'm going to quote a little bit, in one of the major study done by the St. James University Hospital in the United Kingdom, stated that expanded criteria donor grafts demonstrated higher rates of delayed graft function and higher early mean serum creatinine ever. However, there is no significant difference in the 5-year graft survival. But the major concern about this particular expanded criteria donor kidneys is the long-term outcome, which is actually not good according to this particular study. However, another study also showed that the particular long-term outcome of kidney transplantation from ECD donors and compared to the standard criteria donors is that the graft function and the graft survival were similar between the two recipient groups with a mean follow-up of 43 months. And there's not much of a difference between the two, but mean age is different between the two groups, and we need to look at again the long-term outcomes only of beyond 10 to 12 years. A 20-25-year-old getting a 60-70-year-old kidney may not be appropriate. But if at all, if somebody is in low 60s and giving a kidney to a person who is around 55 to 65, probably may be appropriate, and we are prolonging a good, comfortable life for them. So another study from China, a retrospective analysis of this particular expanded criteria donor kidneys, they showed that 1, 3, 5-year graft survival rates of this particular group are 86, 84, and 78% respectively with standard criteria donor, and 95 at 23 and 91. There's not much of a difference between the two groups, but however, the long-term outcome of these particular patients who are older age donors has definitely made some impact in the long-term outcome. So then how can we improve this particular thing? So the age we cannot really change, but definitely there are some other parameters, some other modalities with which we can improve the outcome of our patient who is a recipient when he receives a kidney from an older age person. One is by dual kidney transplantation. Both the kidneys have to be transplanted in situ into a single patient, single recipient. Probably it will improve the graft outcome. The single kidney transplantation with optimal matching, you can see, look at the age matching as I said, probably if it is a 60, you give it to people around 60, around 670, probably you can give it to around 70. And probably looking at other criteria also, the pre-implantation biopsy, the biopsy if at all that shows that less number of glomerular senescence and less of fibrosis, probably we can be choosing that, and the desensitization protocols can be given to the patients initially, and some of the people can get an ATG which is not otherwise routinely given to the patients thinking that they would succumb to the sepsis. The long-term follow-up is also, close monitoring is also required in these kind of people so that we can improve the graft outcome. The concept of dual kidney transplantation is very simple. The children also we can do, and elderly people also we can do. When both the kidneys are given to a young fellow, there can be definitely an improvement in the renal mass. We know that ultimately the kidney disease depends on the number of nephrons, number of glomeruli, and the presence of renal mass. And also the criteria, something like an age, the comorbidities like diabetes and hypertension, cold ischemia time, creatinine clearance, pre-implantation biopsy for allocation, all these criteria should be taken into consideration before allocating the kidney to a person, both the kidneys to a person for dual kidney transplantation. So there are some studies definitely were done with allocation of the dual kidneys to a single patient. They took different criteria for allocation. And one is the donor vessel score, this particular study, and they have taken the pre-implantation biopsy. If the biopsy is showing good, there is not much of fibrosis, the glomeruli are okay and healthy, and all the tubules are back to back, then probably we can actually take up that kidney. And they scored the number of glomerular sclerosis. That based on that they have taken, and along with the tubular interstitial fibrosis and arteriolar narrowing and atherosclerosis factors also they have taken into consideration in some of the studies. And some studies have taken so many criteria of hypertension, donor stability, donor age, elevation of the serum, donor serum creatinine, and the pre-implantation biopsy. After all these things, again they have started allocating. They found that dual kidney transplantation is probably better when you take so many criteria into consideration before allocation of the organ. And the utilization outcome of a single versus the dual kidney transplantation, older deceased donors, United Kingdom also showed that the similar 5-year graft survival in this patient when older graft, aged grafts are utilized in that. However, there is no difference in patient survival demonstrated. That shows that older people, when a proper criteria is utilized and allocation criteria are standardized, probably we can utilize them. So some of the risk factors, some of the criteria were taken into consideration, not only the histopathological, but some of the clinical criteria, of which the KDRI, the kidney donor risk index, which is an estimate of relative risk of post-transplant kidney graft failure from a particular diseased donor compared to a reference healthy donor aged 40 years. So in this ECD expanded criteria donor, when it is taken, they look at the EGFR and similarly the risk factor, the criteria of the kidney donor risk index. And the GFR is more than 60 and the KDR is less than 2.2. Probably you can go with a single kidney transplantation. And the EGFR is less than 60 and the KDRI is more than 2.2, then you can do a pre-implantation biopsy and just assess the score of this particular one. Then it is between 0 to 3. Still you can go ahead again with a single kidney transplantation. If it is between 4 to 6, you have to go for the dual kidney transplantation. If it is more than 7, better to discard the graft, better not to go ahead with the transplantation. So this is the one criteria. The second one is again the KDPI, which we all of us use and we all of us are familiar with, and this combines a variety of donor factors into a single number that summarizes the likelihood of graft failure after a deceased donor kidney transplantation. But this particular cartoon and the graph bar charts also shows that the living kidney donor, the KDR, the half-life is actually better with the KDPI of 20%. And if it's more than 80% or more than 20%, the particular graft survival, especially the half-life is not good according to this particular. So we should take the KDPF less than 20%, which is on par or almost comparable with that of a living donor. So what are the other factors which are taken into consideration when the KDPI score is being made? Which is the age, height, weight, ethnicity, and the donor died because of the heart function with the brain function, then stroke, the history of high blood pressure, diabetes, and hepatitis C, and also the serum creatinine. So these are the factors which are taken into consideration before calculating KDPI. As I said, less than 20 is always better, and more than 80, better not to take the kidney. So this is another whether expanded criteria donor with using the profile of a donor index and pre-implantation biopsy is okay or not. This particular study also showed that, recently published in 2022 in Transplantation International, that shows that the KDPI and a greater histological injury in biopsy, especially the glomerular and vascular lesions, were related to a higher rate of graft failure from expanded criteria donors. So the vessels are not good and healthy as per the criteria taken in histopathologically, better not to go. As I stated initially, that the health of a kidney depends on the vessel anatomy and vessel physiology and the structure and function of the vessels. So it's very, very important for us to have this thing. So again, it comes back to histopathology. The pre-implantation biopsy is very, very important, which whenever such a criteria, such a crisis comes, we always do histopathology on emergency basis in our institute. The Maryland Aggregate Pathology Index, MAPI, this is another one which takes into consideration of the periglomerular fibrosis, arteriolar hyalinosis, the scars in the kidney, the glomerular sclerosis, and wall-to-lumen ratio of interlobular arteries. These are the points which are allocated to each and every criterion, and the 5-year graft survival is better with low when it is a 0 to 7, and if it is 8 to 11, the scoring, which is intermediate with 63%, the 5 years graft survival, and higher and 12 to 15% is the 53% only the survival. So MAPI is also equally important in the pre-implantation biopsy when you are trying to allocate the organs. So better, then how to improve the outcome better? You had to take a kidney, there is no other way. The patient is waiting and requesting for you, then you take it, but see that you properly managed at the time of transplantation with the induction, and the tacrolimus, most of these elderly kidneys are sensitive to the tacrolimus, and gradually decrease the dose, and you can give a steroid-based sparing also at the same time, and minimize the CNI nephrotoxicity predominantly in these patients by giving mTOR inhibitors at the belatacept, or some of the other therapies also can be utilized, so that the nephrotoxicity of the tacrolimus can be minimized. This is one of our grafts which were not taken as the kidney was frozen due to the poor bagging. So this is also one of the reasons why we in elderly kidney we could reject in that. So poor bagging and a frozen kidney was one of the reasons here. So analysis of unused organ donors in the Netherlands, this is another study because the older age associated with a higher risk of non-utilization. So we should utilize more and more organs when properly and optimizing the donor at the time of. And the reasons for non-utilization are predominantly the agonal phase of more than 2 hours in the deceased donors, the long-standing hypertension, diabetes, which is the predominant reasons in our setup also for non-utilization of the organs in our group of people. The presence of renal cysts on the retrieval, our doctors will go and see and they open and they find that the kidneys are actually not healthy. Not only the kidney, many times the liver transplant surgeon also goes and says that liver is cirrhotic and is totally nodular. The pre-implantation biopsy, if it is not favorable, better not to go ahead with the kidney transplantation. So these are the major indications, the prolonged cold ischemia time, the presence of hypertension, diabetes for a long time, and the presence of abnormal kidney in the form of a renal cyst and abnormal kidney biopsy which is not healthy, so better not to go ahead. So Jeevandan is a cadaver transplantation program of government of Telangana, and for the past more than 10 years, and the very person behind this particular program and this particular logo is also here in the audience, Dr. Swandalata, who actually had taken the task of taking this program for higher heights and for more than 10 years. And this particular program, and yes, she deserves an applause definitely. And this particular, she recently retired and handed over the headache onto my head actually now. So for that, I don't want to clap actually, you can clap. And this particular, during her tenure, and we realized that their expanded criteria donor were almost 229, and of which the total single kidney recipients, single kidneys were utilized in 208, and the dual kidney transplantation to a single recipient was done in 21 patients, and only single kidney was used. Other kidney was discarded for so many reasons, something like a cold ischemia time and so many other reasons, maybe other kidney, maybe a smaller one, something like that in 17. The mean age of this particular, the donors is 64 years plus or minus is 4.95 approximately. So almost 70 years. Recently we got around 72-year-old and donor and the kidneys are doing very well with both the kidneys. And predominantly the males with 158 and the females with 71. And to conclude, it is essential and to carefully assess the risk and versus the benefit of using the older deceased donors before the allocation, because we know that there is a lower graft survival in them, the higher risk of delayed graft function, which ultimately culminate in a poor graft function at the end of the day, and increased risk of rejection, where you'll be landing up and giving lot of immunosuppression in such a way that patient can succumb to the sepsis also at the same time. So because of these reasons, you should be careful in assessing the using the before utilization of the deceased donors of the older age group. But it is a case by reevaluation is very, very important, especially when the patients are waiting in the list for a very long time. And every donor referral is a worth referral. And the effort of donation professionals should be balanced, because you are doing a lot of effort. The entire system gets alert, and the serious, even the midnight 1 o'clock to early morning 7 to 8. And you are doing such a huge effort, and ultimately the patient outcome is not at all good, and it will not be useful. So you have to assess that also before going ahead with an experimental, whether you can take a 75-year-old or 72-year-old kidney and a transplant without any major good outcome. At the same time, the absolute increase in the number of organ transplantation is required, or is it worth of pricing, taking the price of a decreased utilization rate? Whether you can just think about it, whether you only to increase the number of transplantations versus the number of the kidneys which were not utilized. But for me, the number of transplantations is not at all required. Though equally important is the number of the utilized organs, but it is ultimately the patient life and the longevity, and a successful transplantation is more important than the absolute numbers of the number of transplantations or the number of organs utilized. Thank you very much for the kind attention and the patient hearing.